Ladies and gentlemen, it's a pleasure to present a talk on glycemic control in the ICU during the 17th Congreso Uruguayo de Medicina Intensiva. My name is Charles Preiser. I work in the Erasmus University Hospital in Brussels, Belgium, and I've been involved in the field for about 20 years. I've got some disclosures to declare with companies also involved in the field. So the field is the field of tight glycemic control in the ICU. The initial enthusiasm was really huge and raised by the first study from Great Vandenberg and co-workers in Belgium, showing a dramatic improvement in survival of patients randomized to tight glycemic control by intensive insulin therapy, and this was in 2001. After this initial study, several other confirmatory studies, including the one I've been involved as a principal investigator, will control, all failed to confirm these impressive results of improved survival just by tight glycemic control. Accordingly, the enthusiasm somewhat decreased over time. When you look at PubMed and you use the keywords glucose control in ICU, you can see that from 2009 to now, there is a descending slope suggesting a decreasing level of enthusiasm for the topic. However, we learn a lot of important issues that are still useful for our daily practice, even 20 years after the publication of the initial study. First, we learned that safe, efficient glucose control is not easy to achieve in contrast to the initial beliefs. Second, that the definitions and understanding of the three domains of dysglycemia, hypoglycemia, and high glycemic variability are evolving over time, and we are improving our understanding of these three domains. That the issue of ICU acquired diabetes is probably underexplored, but that is a real public health issue. And finally, that we have a lot of unanswered issues, and to get the answer, we need reliable research tools. So first, safe, efficient glucose control is not easy to achieve. Even in the context of the interventional studies, you can see that achieving the range you are supposed to get in is not that easy with insulin. So either the tight range between 80 and 110 milligram per deciliter. A lot of studies were unable to achieve as an average in the patient randomized to this target range, where a lot of patients did not achieve this level. It's not easy to achieve. And when you compare to a control group, the control group has usually a blood glucose level around 150, even when the target for this control group is 180 to 200 as in VISEP and the two Leuven studies. In fact, the achievement of a predefined blood glucose level is a complicated process involving several steps. First, you need to get a good blood glucose measurement, meaning that you need first a good sample, preferably an arterial one or a venous one. Capillary sample is less reliable in critically ill patients. You need to get a good meter, either a blood gas analyzer or the central lab. The point of care device is less reliable in critically ill patients than the blood gas analyzer. You also need to know if you are measuring it in the blood glucose in whole blood or plasma or serum, and also the accurateness of the meter must be checked. Then you need insulin. If the blood glucose level is higher than the one you want to target, then you need good pumps and also a good line to infuse the insulin. You can hardly get reliable control with cutaneous infusion. Peripheral intravenous infusion may be less reliable than central venous infusion. And you can also avoid inaccuracies or improve your practice if you infuse insulin alone and you don't push any other drug in the same line than insulin. Therefore, you need accurate syringe pumps. Then you need an algorithm for the insulin dosing, and you need preferentially a dynamic algorithm stating that according to the level of blood glucose you mentioned and the time from the previous reading, the algorithm will tell you how much insulin you should give and when you need to do the next check. You can get also closed loop systems to connect continuous glucose monitoring with an insulin pump, but this is still at the experimental stage. And finally, you need motivation and skill of the nursing team. We looked with a nurse a few years ago to the workload related to the blood glucose control when you want to do intensive insulin therapy. And we measured that the time devoted to glucose control was increased by 17% when you want to implement intensive insulin therapy as opposed to the liberal way to control blood glucose. Then a second issue that we learned over these 20 years is that the definitions and understanding of the three domains of dysglycemia were improved over time. These three domains are hyperglycemia, hypoglycemia, which is often iatrogenic, induced by insulin, and the high glycemic variability. All these domains are independently related to a poor outcome, and when several of these glycemic events are present, then there is a synergy. So stating that patients having all three episodes of dysglycemia are much more likely to get a poor outcome, including higher mortality, than patients who do not get any of these dysglycemic episodes. First, let's look at hyperglycemia. We know for the literature in the field of biology and also from human data that cortisol is the stress hormone. Cortisol induces hyperglycemia, and in fact, the conclusion or interpretation that stress hyperglycemia is an essential survival response is supported by some data suggesting that you need some degree of hyperglycemia to survive an injury, at least during the early acute phase. In fact, restoring normal glycemia may sound like tricky. 80 to 110 milligram per deciliter, which are the normal values, which is the normal range in healthy patients, can be considered as normal glycemia in fasting conditions. These are the values considered to exclude glucose intolerance if you go to a lab on the morning and if you got blood glucose level below 110 milligram per deciliter, you are sure that you are not diabetic. What about critically ill patients? These patients are under stress, so blood glucose should be higher because of the stress itself and the cortisol and other hormones. Usually, critically ill patients are fed, are not fasting. And finally, they receive therapies such as corticosteroids or other therapies that are likely to increase blood glucose by themselves. And in fact, the resistance to insulin in the critically ill patients is the underlying mechanism of stress hyperglycemia. We looked with a team from New Zealand at the insulin sensitivity over the first 3 days of the stay of ICU patients, and we found that the insulin sensitivity was really very low, or that the insulin resistance was very high, and was in fact much higher than the patients with type 2 diabetes. So the sensitivity to insulin, if you prefer, is much lower in critically ill patients than in patients with type 2 diabetes. Exactly as if insulin resistance was a kind of adaptive mechanism evolving during the first hours of the critical illness. In fact, stress hyperglycemia can be related to insulin resistance, but also to some treatments and, of course, to the illness itself. So there are several different causes of stress hyperglycemia. When we looked at the literature, and this was with the collaboration of a team in England, we looked at we did a scoping review on the consequences of stress-related hyperglycemia. We found 43 eligible studies, mainly from the US and Canada, and mostly in patients with trauma. The definition of stress hyperglycemia was variable from one study to another: 150 mg per deciliter for 10 studies, 180 for 4 studies, and 200 mg per deciliter for 14 studies, and intermediate values for others. So there is a lack of harmonization and a lack of homogeneity in the definition of the name hyperglycemia itself already. And you can see on the right y-axis that the number of patients considering those association studies is really very important, almost 500,000 patients in total. Then when we looked at these observational studies in terms of outcomes reported, we can see that a lot of different outcomes were reported by studies. On the x-axis, you can see the number of studies, and within the boxes, the rectangles, you can see the corresponding number of patients in whom these outcomes were recorded and reported, in fact. So you can see that the mortality was the most commonly reported, but with different time points. But there was an association between higher hyperglycemia and a higher rate of mortality, which is in fact which can be interpreted as a surrogate marker, as hyperglycemia being a surrogate marker of the severity of disease. So a lot of different outcomes were recorded. So one of the questions raised by these findings and others is what is the optimal blood glucose level in patients with chronic hyperglycemia, either patients with poorly controlled diabetes or patients with unknown diabetes, and in whom we discover that there is diabetes when they are admitted in an ICU. In fact, we know that patients having a chronic hyperglycemia develop intracellular mechanisms to neutralize the toxicity of high glucose levels, but these mechanisms take months and years to develop. This is not the same time scale than in critically ill patients. And we know that the association between mortality and blood glucose level is shifted to the right in patients with chronic hyperglycemia. This is the blue curve, the blue line on this graph. You can see that the J-shaped is more impressive and more marked in the patients without chronic hyperglycemia, the red curve, and then there is a shift to the right with of the blue curve when in patients with chronic hyperglycemia. This can imply that in those patients with chronic hyperglycemia, a different target should be used. And indeed, when the team of Leuven, Belgium, looked at the benefits of thyroid glucose control according to the presence or the absence of pre-existing diabetes at the time of ICU admission, in fact, there was no benefit of thyroid glucose control in those patients with diabetes. Now we can compare the blood glucose level recorded at admission in the ICU with the usual blood glucose level that we can calculate in patients with chronic hyperglycemia by using the glycated hemoglobin, so the A1C level, which is a reflection of the chronic blood glucose level. There is an equation published by Nathan a few years ago that helps, that can be used to convert the blood glucose, the A1C level, into the estimated average blood glucose. And when we looked at the glycemic ratio, so the admission blood glucose divided by the estimated average glucose, we calculated the so-called glycemic ratio. We could find that the glycemic ratio associated with the best survival was when was closest to 1, meaning that in those patients with severe hyperglycemia, severe chronic hyperglycemia, hyperglycemia at admission could be associated with a better outcome than a lower value. So we should know the pre-existing or the average blood glucose value before choosing a target. This was also observed by a team of endocrinologists in Australia. The outcome was not mortality, but the need for ICU admission, and they found basically the same findings than us. They called this the stress hyperglycemia ratio, but this was the same calculation. Now the issue of hypoglycemia, which is highly relevant in terms of safety of care. The treatment can be worse than the disease, and in fact this was shown by for instance, by the team of the NICE Sugar study, a large study performed in Australia, published in 2009, and this post-hoc analysis was published in the New England Journal of Medicine in 2012. They looked at the association between hypoglycemia and risk of death in critically ill patients, and they found that indeed any level of hypoglycemia was associated with an increased rate of death, regardless of the cause of hypoglycemia, either iatrogenic, related to the insulin treatment, or spontaneous. And the increase in mortality was really highly significant, from 40 to 300%. Judy Jacoby from the US also looked at the mortality in patients with hypoglycemia developed in the context of interventional studies, and she found that the rate of mortality was multiplied by a factor 5 in those patients who developed at least one episode of hypoglycemia. What about the definition of hypoglycemia? In fact, it could be the same than the same story than for hyperglycemia. In fact, the issue of relative hypoglycemia might be relevant. In fact, if we call hypoglycemia as a blood glucose level lower for at least 30% than the usual or the pre-hospital blood glucose level, we can also see that the mortality is largely increased in those patients with relative hypoglycemia, as shown on this slide. So the red curve, patient without relative hypoglycemia as defined, and the blue curve, patient with at least one episode of relative hypoglycemia, so blood glucose lower than 30% lower than the usual value. And in fact, the relative hypoglycemia was one of the strongest predictors of mortality in those patients with diabetes. Now, if hypoglycemia is dangerous, we need to understand why and how. In fact, brain is probably the most sensitive organ. We know that glucose is an obligatory metabolic fuel for the injured brain. There are no cerebral stores of glucose, and the glucose diffusion diffuses from plasma to neurons and astrocytes on a concentration-dependent manner. And in fact, experimental data and clinical data are clear and consistent. In case of severe hypoglycemia, there is a fall of ATP and cortical activity measured by electroencephalogram. So, if we looked at some pediatric data in children randomized to two regimens of blood glucose control, we can see that several years after ICU discharge, the prognosis and the ability of the children to perform cognitive tasks is impaired in those children who experienced at least one episode of hypoglycemia during the ICU stay. Now the issue of high glycemic ability. This is quite caricatural picture. On the left hand side you can see the high variability, and on the right side low variability. So the average blood glucose is the same, but the swings are much higher in the left than in the right. In fact, we know for long that changing the amount of or the concentration of blood glucose into the medium is very toxic for the cells. This was shown by several teams, including this one, and also in the patients with diabetes, the oxidative stress is proportional to the magnitude of glycemic variability. Now, there are different indices to measure variability. The simplest one is the standard deviation, or the coefficient of variation, which is the standard deviation divided by the average blood glucose. But this is very simple, and it's influenced by the number of readings of blood glucose you can use for your calculation. Hence, it's probably more appropriate, as known by the diabetologist, to use time-weighted indices of glycemic variability, such as the other listed on this table. Nevertheless, this is a very nice study showing that the variability of blood glucose expressed by the standard deviation is a stronger predictor of mortality than the average blood glucose itself, suggesting that the hidden killer is the variability rather than the absolute blood glucose level. And indeed, this was also confirmed by Jamie Crinsley in a large cohort of patients. Variability was found as a strong independent predictor of mortality. We looked with an Italian group at different indices of variability, and we found that the GLI, the glycemic liability index, was a better predictor than the others. But in any case, the three different indices of variability were a stronger predictor of mortality than the mean blood glucose, just confirming the data from AGI that I showed you two slides ago. We also looked with a team in the US in a cohort of septic patients, and we basically found the same conclusions than GLI, so glycemic liability index, and the mean amplitude of glycemic excursions were better predictors of outcome than the standard deviation itself. And you can see on this slide the size of glycemic liability index plotted against the observed mortality. So you can see that the higher the variability, the highest the mortality. And this relation can be slightly different according to the pre-existence of chronic hyperglycemia. We looked at this with Jamie Crinsley, and we published this a few months ago in Critical Care Medicine. So the interaction of acute and chronic glycemia was shown on the relationship between hyperglycemia, hypoglycemia, and glycemic variability. So the associations differed between patients with a normal blood glucose value, normal chronic blood glucose value, or abnormal blood glucose values. Then we also learned during these last 20 years that patients can become diabetics in the ICU. In fact, the prevalence of diabetes is not exactly known, but there are several reports showing an increased rate of diabetes after an ICU stay, and it's probably wise to include the diabetes mellitus, type 2 diabetes mellitus, in the context of the post-intensive care syndrome, such as the cognitive disorders, the mental disorders, and the functional disabilities. There are other disorders that are underexplored, but are the consequences of stay in an ICU, and the diabetes, type 2 diabetes, is probably one of these. In fact, when we looked at some cohorts, two from Croatia, one from Scotland, and one from Belgium, you can see that when these are plotted and meta-analyzed, so that there is an increased risk of a factor 3.5 to become diabetic after a stay in the ICU when you looked at these large cohort studies. No, we got a lot of unanswered issues, and then we need some reliable research tools to get the answers. We need continuous glucose monitoring to get a safe and effective tag glucose control. We looked at the benefit of continuous monitoring in a cohort of 77 patients randomized in our department. 2 units were randomized to get a standard care, and 2 units were randomized to the nurses were allowed to use the values of blood glucose displayed on the screen. And we were able to show that the rate of hypoglycemia was divided by a factor 4 in those patients randomized to the unblinded group, so the nurses were allowed to use the values of blood glucose displayed on the screen. In the blinded group, so there was no values of blood glucose displayed on the screen, but the values were measured and recorded, but the nurse didn't get access to these values. So this was a nice demonstration that the use of continuous monitoring, in this case an intravascular glucose monitoring, improved the safety of blood glucose control in our target range, which was 80 to 150 milligram per deciliter at this time. So you can build closed loops systems connecting the continuous monitoring with an artificial pancreas or an insulin pump, if you wish, and this improves the time in range. You can see on the red areas in a small study of about 12 patients in each group. So the closed loop is depicted in red, and the local protocol and standard of care is depicted in gray. You can see that the time spent in the target range, in this case 6 to 8 millimolar, is much higher in patients randomized to the closed loop systems than the controls. So the safety and efficiency of blood glucose control needs this type of device. This was also shown by a team in Japan after digestive surgery. They also observed that the time spent in the target range was much better, was much higher in those patients treated with an artificial pancreas. So the glucose control in the ICU is definitely not over. There are a lot of questions that need to be addressed, and for this purpose we need a close collaboration with the industry to be able to use closed loop systems connected to reliable continuous monitoring.